tego?
Mamy.
A umiesz defrizować to?
Kiedyś umiałem.
Bo ja nie wiem, jak to jest freeze teraz. A to na pilocie jest freeze?
Ladies and gentlemen, I have a pleasure to welcome you on the final day of 18th Warsaw International Medical Congress. First of all, I would like to invite you to our lecture by our amazing guest, all the way from Croatia, Professor Ilan Stoyanevich, with the lecture titled Ethical Issues in Neonatology, Where Are We Heading?
Difficult issues during my entire professional work was communication as the first one, and just following ethics. And well, I just want to share you frankly what I learned during my entire professional lifetime, and also which cases I have been dealing with. Well, let's start. I have no conflict of interest. However, I delivered the lecture, part of this lecture with my students in Zagreb, at Zagreb University. And the aim is to speak about the limits of viability in neonatology. I will tell you what is the definition. Then I will also talk about the prenatally diagnosed congenital malformations. Then I will talk about the ethical issues at the limits of viability and infants with the congenital malformations, severe and lethal congenital malformations. Then I will talk a little bit about the futility of treatment. You will see what it is in fact. Then about basic principles of bioethics, then about very difficult issue withholding and withdrawing the treatment, and something about the new concept of perinatal palliative care. So when we are talking about the ethics, well, we should say when we are faced with the ethical issues, firstly, we are strongly faced with ethics when we are communicating the information. Information which we are communicating is not only to the patient, because the patient is probably in utero or just outside the uterus, but he doesn't have autonomy. So we are talking to the mother or to the parents or to the family. Then, when we are establishing the indication for the treatment or whatever we are going to do with the patient, and then when we are making the diagnosis, then when we are performing the treatment, what we are going to do, and then about subsequent decisions after the treatment. And of course, if we are at the end of the life of the infant, then we are also going with the parents through the grieving process, and neonatologist is very responsible for communicating with the parents till the end of the grieving, at least in the first weeks or are infants at the limit of viability. The other ones are those with congenital malformations. And the third one is those who we are intensively treating at neonatal intensive care unit and who then deteriorate their condition, and that this condition is making us very unhappy because we have to do something which is not very good for the baby and for the parents, because the outcome would be not that good as parents expected. Because every parent is expecting healthy baby and baby who will survive. So I'm asking myself, if we are gods when talking about those infants. Of course, we are not, and we should not behave in that way. We should say frankly what we are capable of, and we should be empathetic as much as possible with the parents, and also to say what are our limitations concerning the treatment and all other things which are connected with the baby. So empathy is the most important thing which we should express. Now about limits of viability. So when we are talking about the limits of viability, that means that these are infants who have physiological capability to survive outside the utero and to be live-born. And, you know, this is the definition which is now made by WHO, and it is still around 30 years old. And nowadays, we consider that these are infants at 22 weeks of gestation. And we call them usually extreme premature infants, infants at the threshold of viability or micropreemies. Well, you know, what I would like to say is, at the moment, we have 22 weeks, but still American College of Obstetrics and Gynecology, they are decreasing this limit to 20 weeks, and we don't know where is the end. Well, this is a little bit busy slide, but when you look at the slide, premature infant is one who is born before 259 days or 37 weeks of gestation, and you can see that these here are extreme premature infants, these here are mild premature infants, and these here are late. But I won't pay attention to those term infants, because I'm going to talk only to those. You know that nowadays about 15 million preterm infants are born at the world, and that prematurity rate, overall prematurity rate in the world is around 11%. So, you know, but these infants at the limits of viability, which you can see here, they are just below 1% of all premature infants, but they account for almost 3/4 of mortality and morbidity. So they are the most problematic ones for which we care for. Another definition of limit of viability is that this is gestational age at which at least 50% of infants are surviving. You can imagine that in some days this was not 22 weeks of gestation, that this was much more weeks of gestation, and I will show you later on how was it concerning the history. And as I said before, this is really physiological capability of infant to survive ex utero. This is dependent on a certain unit which is capable of taking care for those infants.
But this is also very important how perinatal care has been organized in one society. Is it well or badly organized? Is there a possibility of those infants to be transported in utero to the centers where they can get ultimate care? So, you know, not only capability of the unit is important, neonatal intensive care unit, but also the capability of the organization of perinatal care. So, organization of perinatal care is very important, and I would pay attention to you that regionalized perinatal care is very important. It began in the 70s in the United States and Canada, and nowadays it is one of the very important levels of care in developed countries. But in developing countries like Africa, Southeast Asia, and so on, it is not a good model of organization of perinatal care because they don't have means to do it in that way. So we should do something else. Well, you know, when we are talking about the infants at the limits of viability, we are always talking about miracles. So you can see here that there was a male infant of 268 grams who survived with just retinopathy of prematurity. Nothing major happened to the infant. And female, it was born in 2020, it was 212 grams, and also without major morbidity. So nowadays, maybe these are miracles, but we will we are now faced with the possibility that this will not be only the miracle. This could be just the rule that the infants at the limits of viability are also surviving very easily. Now I would like to share with you some experience from other countries, from let's say one very developed countries like Sweden. You can see if one is born at the limit of viability in one center here, this is this orange bar in Oribo, and if it is born in Stockholm, this is this blue bar, you can see that the difference of infants who survived till 1 year of age is 57% in Oribo and 74% in Stockholm. That means it is not the same where you were born. So it matters where you are going to be born in terms of survival and in terms of morbidity and mortality as well. So these are data from my hospital. You can see that in my hospital between 2003 and 2018, limit of viability was between 26 and 25 weeks, and it was far behind developed countries like Canada and United States, where it was at the same time set at 24 weeks. And that means it is individual. You should have your own data in order to define limit of viability and to counsel the patient. You can't counsel the patient on others' data. You should have your own. What counts is also really what is the survival rate of those infants without major morbidity. What is major morbidity? Major morbidity is intracranial hemorrhage, grade 3 and higher. It is bronchopulmonary dysplasia, and it is also retinopathy of prematurity. These three conditions are affecting quality of life of those infants. And that's why it is very important how many of them survive without that major morbidity. You can see that this is dependent on gestational age. And you can see that the numbers without major morbidity are very low at 23, 24, 25 weeks of gestation. And after 26 to 28, it is increasing. That means that we are not that much good in treating those infants at the limits of viability. So we should improve something in order to do that. How was it historically? Well, you can see here the data are from Sweden because they have good data, reliable data, and you can see that in 30 years, limit of viability, it moved from 26 weeks at the middle of 80s to 22 weeks in the middle of 2000s or 2015. So you can see that every, let's say, 10 years, limit of viability was going up from 26 to 22 weeks of gestation. And nowadays, they have very good data in Sweden. I will show it to you a little bit afterwards. So how to define viability from the point of view of medical staff? So medical staff is talking about viability in terms of who of those infants, how many of us are going to treat most of them based on the data we have. So viable are those whom nearly all medical staff would resuscitate or would care for. And in developed countries, they made some research, and these were infants at 25 weeks of gestation. And non-viable are those whom most of the doctors and nurses would not treat, and they are at 22 weeks of gestation and below. And those in the middle, they are between 23 and 24 weeks of gestation. But it is questionable whether is it good or not criterion from the ethical point of view. So nowadays, as I said, this is the situation with the infants the infants at the limits of viability from the point of view of developed countries. But from the point of view of developing countries, you can see that if one is born at 28 weeks of gestation, it has 95% probability to die if neonatal care is not accessible. So, and there are only 1% of infants at 28 weeks of gestation who have access to neonatal intensive care unit. So if you look at the world's data, then probably most of those infants are dying, although they are just 1% of infants, but they don't count. These are data from Ghana. You can see that at below 26 weeks of gestation, most of infants are dying. 80% of them, 20% or below, are surviving. And limit of viability is somewhere between 26, 27 weeks and 31 weeks of gestation. And of course, they have here access to neonatal intensive care. So, what is recent Swedish experience? Recently, they published a paper in 2018 saying that infants at 22 and 23 weeks of gestation are surviving at 22 50% and 23 60% without major morbidity. That means that they are very close to that limit of viability as it has been defined before, survival above 50% without major morbidity. But this is Sweden, this is not the all of the world. And that's why I'm showing this table here. You can see that these are zones which in fact are gestational age, A, B, C, and D. And you can see that intensive care in zone A is not indicated, and in zone D it is recommended. And in zone B and C it is not recommended, but those zones here, they are just different because this here burden of intensive care is likely not to be acceptable, and here in that zone C, likely to be acceptable. And also, it is dependent on parental decisions concerning the intensive care and the treatment. Here, parents can have, I mean, they are having a very important role because they can say that they don't want to treat the infant to be resuscitated, and in this zone they can't say that. And the healthcare providers should treat the infant in that zone D. In fact, the authors who made this table, they claimed that this here probably in developed countries should be, as I said before, 22 or below and 25 or above. And here between 24 and 23 weeks of gestation. So you can see that in different countries it could be different, but how can we manage it in terms of ethics? So which are ethical dilemmas? To resuscitate or not, to treat or not to treat, is intensive care indicated, and how prevent severe morbidity, and there are many others which of course I cannot talk to you. These are factors which are influencing the outcome of infants at the limits of viability. You can see that this is gestational age, antenatal steroids, gender, birth weight, possibility of socioeconomic status, and factors which are not attributable to medical factors, but just to the organization of care at the neonatal intensive care unit, or even in the society. So these are very important factors. Concerning the prenatal factors which are influencing survival of infants at the limits of viability, you can see that cesarean section is lowering the risk of death just in the first day of life, but not afterwards. While steroids, prenatal steroids, they are influencing survival of those infants almost 1 year till 1 year of age. While vaginal bridge delivery, it is influencing their mental status. So this means that these factors we should always take under consideration when we are talking about those infants. As I said before, these are 3 diseases which are very important. They are considered as major morbidity for those infants, and they are influencing very much their outcome and the quality of life. As you can see here from this a little bit busy slide, if you look at the spectrum of disability among surviving extreme premature infants, mild disability or no disability is increasing. The number of infants who are without major disability or who have mild disability is increasing with increasing gestational age. While here you can see that severe disability is increasing with decreasing gestational age. So that means that most of the infants at the limits of viability will be severely disabled or severely damaged. So this is, and this has also long-term effect on their survival. You know, we are dealing, when we are talking about the infants at the limits of viability, we are dealing with so-called postnatal growth retardation. And you can see here from the Swedish data that these are limits, infants at the limits of viability, those gray bars here, and these are percentages of infants with postnatal growth retardation throughout the 11 years, and you can see that most of those infants will have postnatal growth retardation in terms of weight and length till 11 years. But this is decreasing. And if we look at the growth of the brain or of the head, you can see that this is just the same for the entire 11-year period. That means that most affected organ when we are taking care of those infants is the brain. So we should also take this under the consideration when talking about those infants. And these are special educational needs. Special educational needs are increasing with the decreasing gestational age. You can see that almost 50% of those infants will have special educational needs at the limits of viability. And now I will talk a little bit about the infants with life-threatening congenital malformations. They are, you can see here, this infant here who were detected prenatally by ultrasound. You can see here that it doesn't have head. What do you think? Is it live-born infant or not? What do you think? Is it live-born? Does it have any signs of life? Yes, of course, it is live-born, yes. So this infant has been born as live-born infant. And how was it born? Vaginally or by C-section? C-section. Why? Yeah, because no head. And here you can see infant with mermaid syndrome. It has Potter fascias. You can see here anencephaly acrania, the other infant, encephalocele here, and here Patau syndrome sent home alive also. It is now, she's my patient and she's now in Japan. And here infant with rachis. Here hemifacial microsomia, golden heart syndrome. Here diaphragmatic hernia. Here aneurysm of vein of Galen with insufficiency, cardiac insufficiency. Here you can see collodion baby syndrome. You can see here this baby who has been treated in our unit. Also bullous epidermolysis, cutis laxa congenita. Also the baby you can see, and also sacrococcygeal teratoma. Well, we have the possibility to detect all those infants by ultrasound, but still the mother is the one who will decide whether the baby should be treated or not, and because the patient, our in utero patient doesn't have autonomy. So ultrasound is enabling to make the diagnosis, but to treat the patient, it is the responsibility of the mother. And now, at the end, I will just go through very important definitions. So, futility. You know what is futility of treatment? That means that there is no possibility of treatment of the baby who will certainly not survive the treatment. But when you are counseling the patient, you should know that everything in medicine is just relative. That means when you are talking about, let's say, renal agenesis, you can see that probability of live birth is not reported, but here, longest reported survival is 13 months. Anencephaly, longest reported survival is 10 months. Thanacophoric dysplasia, 5 years, 9 years, and so on. So you should know that, and you should always share those information with your patients, and you should always share information what you know and what you really don't know. And at the end, how should the doctors behave? They should respect autonomy. In fact, you should tell to the patient what you know and what you don't know, and what happens during medical care. And you should also know that those patients who we are caring for, they don't have their autonomy. Parents should decide on their behalf. And this is the problem from the medical point of view. Then also the other is non-maleficence. That means that we should communicate to the patient in a very decent way that we care for the patient, that we are empathetic, and that we understand patient's situation. The other very important principle is principle of beneficence. That means that we should step into the patient's shoes and tell them very empathetically what we are thinking about the treatment. From the medical point of view, that means you share with the patient always only medical information and not giving them the answer what you would like to hear, but they are the ones who will answer their needs. And justice, that means that you understand the patient and that you are on patient's side. And at the end, I would say something about perinatal palliative care. So it is no new concept of care. That means that withholding or withdrawing the intensive care does not mean stopping treatment. It means that we are just redirecting active treatment to a different approach. That means from active treatment towards the palliative care. And this is very important in terms of ethics. And the patients should understand that. And you should inform them about everything which will be happening during palliative care. And this is very important for them to understand. So these are 4 main principles of ethics, bioethics. So principle of beneficence, non-maleficence, autonomy, and justice. And what we are in fact doing, we are in fact trying to increase the resilience of individual or of the family or of the mother and the society to empower the recovery. And this is really practice which has been developed and described by Antonovsky in the 70s. This is so-called salutogenic approach. And this salutogenic approach is very important. We should inform the patients what we can do and what we cannot do, and that we do not have supernatural powers. And the most important from ethical point of view is first, do no harm by overdoing or undoing. And I think that if doing no harm, then we are probably on a good track. We are heading in the right direction. Thank you.
Thank you so much, Professor, for this inspiring lecture. And now I would like to invite all of you to the plenary session. Please welcome Bartosz Korzep and Emilia Włoszek, coordinators of the plenary session. The floor is yours.
Good afternoon, ladies and gentlemen. Our Congress is approaching the end, but we are pleased to welcome you to plenary session of 18th Warsaw International Medical Congress. First of all, please let us introduce ourselves. My name is Bartosz Korzep, and this is my colleague Emilia Włoszek. We have a great honor to host this session.
First and foremost, we would like to introduce our honorable jury who devoted their time to join our session. Please welcome His Magnificence, Professor Zbigniew Gaciąg, Rector of Medical University of Warsaw.
Professor Piotr Pruszczyk, Vice Rector for Science and Technology Transfer.
Professor Michał Gront, Director of Doctoral School.
And of course, our keynote speaker, Professor Milan Stanojewicz.
Last but not least, we would like to welcome our active and passive participants. Thank you very much for joining us today. We are sure that this session will delight all of us.
Now, I would like to remind you the rules of our plenary session. Every presentation may take up to 7 minutes. After that, we have 3 minutes for discussion. Official language of the presentation is English. The winner will be chosen by our jury, and the results will be announced at the closing ceremony.
Okay, the first speaker is Mihaly Shekeli, the winner of Basic and Preclinical session, with his paper entitled The Impact of Protein Arginine Methyltransferase 5 Mutations on Cancerogenesis. We would like to invite you to the platform.
Okay, the floor is yours.
Dear jury, dear audience, I'm Mihai Seke, and I will talk about the impact of the mutation of protein arginine methyltransferase 5 on tumorigenesis. Cancers are among the leading causes of death. They arise from the mutations and epigenetical modifications of protein responsible for maintaining the normal cell cycle. Protein arginine methyltransferase 5 is an epigenetical modulator which catalyzes the symmetric dimethylation of the arginine residues of histone proteins and thus regulates gene expression. It is active in a heterooctameric methylosome enzyme complex. Its main interactory partner is MAP50. Its regulation is done through its threonine 80 amino acid residue, which is phosphorylated by RhoA activated kinase, which activates the enzyme, and it's dephosphorylated by myosin phosphatase, which inhibits the enzyme. Myosin phosphatase consists of a MIP1 regulatory subunit and a PP1C catalytic subunit. It has an important effect of carcinogenesis. Our work group has previously identified a proto-oncogenic signaling pathway in hepatocellular carcinoma in which ROC activates PRIMT5 in the cytoplasm, which then translocates into the cell nucleus and alters gene expression in a way that it represses tumor suppressors and promotes tumorigenesis. The enzyme has high mutational frequency in bladder cancer and lung cancer and other cancers as well. The main mutational side is its regulatory residue, threonine 80, and this is the reason why we aimed at biochemically analyzing the result of the threonine 80 alanine mutation. We first overexpressed the wild type and the mutant proteins. We used a flag-tagged plasmid with which we transfected TSA 201 cells, and after the lysation we could detect both the wild type and both the mutant proteins. With these proteins we did in vitro assays. We first analyzed its residues. So with M2 affinity gel we bound the primed to agarose beads which are bound to anti-flag antibodies, and upon ROC treatment the result was that it becomes phosphorylated on the wild type enzyme is phosphorylated on its normal regulatory residue. However, because of the mutation, this is not apparent at the mutant protein. However, a new serial residue appears because of the mutation. We wanted to find out exactly which serial residue is it. So we did mass spectrometry analysis, and we found that the newly appearing residue is the serial 74. We also did activity assay with which we measured the activity of the mutant enzyme, and we found that its substrate was significantly more symmetrically dimethylated. Therefore, the enzyme's activity increases because of the mutation. Then we wanted to analyze if the normal regulators of PRIM5 actually regulate the newly appeared serial 74 residue. So we first incubated with ROC, and we experienced that the phosphorylation level rise. And then we incubated with myosin phosphatase, and we experienced significant decrease in the phosphorylation levels. So indeed, this residue is regulated by the same threonine 80 residue. Then we wanted to figure out the method of which the mutation increases the activity. And we measured in a cellular experiment, we measured the amount of the interactory partner, MAP50, bound to the enzyme, and the amount of substrate bound to the enzyme. And we measured this after phosphorylation, and we measured it in the mutant samples as well. And we found that there was not a significant change in the binding of the interactory partner, not because of the phosphorylation and not because of the mutation. However, upon analyzing the binding of the substrate, we found that in the wild type, there was a significant rise in the binding of the substrate upon phosphorylation. But what is more important, that the mutation itself changed and increased the binding of the substrate. So the mutant enzyme's activity increased because of the mutation, the activity increased in the mutant proteins, and it is because of a structural change in the enzyme that it becomes constitutively active. Our work group had access to human lung cancer tissue samples, and therefore we analyzed the activity of the enzyme in these samples with Western blot analysis by analyzing its threonine 80 phosphorylational site. And we found that there was a significant increase in the phosphorylational levels in the tumor samples. However, there was in most of the samples, there was no phosphorylation of serial 74. However, there were a few samples when we did not experience any threonine 80 phosphorylation because of the mutation. And in those samples, we measured serial 74 phosphorylation levels, and there was a significant increase in that. So we can conclude that the normal enzymes ROC and myosin phosphatase loses their ability to regulate the mutant enzyme, and because of the structural change in the protein, it becomes constitutively active and symmetrically demethylates histone proteins and represses tumor suppressor proteins. And we hope that this mutation can be used as a tumor marker in the future. Thank you very much for your attention.
Thank you, and now it's time for questions and discussion.
Just for beginning, is this only one type of mutation, like I don't know, point mutation, deletion, whatever, or there are different mutations within the gene? That's my first question. And the second question is, what was your personal input in this project? So in other words, what did you do in this study?
Okay. Yeah, for the first question, there are several mutations responsible for the alteration of the activity. These are point mutations which have different effect of the activity. There's another mutation which is in leukemia, and we did not analyze that mutation. I was doing the cell cultures, and I also did the assays, kinase assay, activity assay. I did the mass spectrometry analysis with help, and also this experiment I've had help with, and the Western blots I also did myself.
Do you have any insight into the prognostic relevance of this mutation, whether this is associated with more or less aggressive tumor behavior?
We are still measuring. We have a sample bank, and we are trying to increase the sample bank size, and we have preliminary results on in what kind of lung cancers they develop, and they are mostly cellular carcinoma, but there are small cell lung cancers as well among the samples, and we found that there was a correlation between the rise in activity and the status and the grade in these patients.
Actually, at the very beginning, you mentioned I'm sorry, I must admit, at least on behalf of myself, I'm not an expert in tumor genetics, but you said that you can find this kind of a mutation in different types of cancer tumors, so maybe this is not relevant for the process of carcinogenesis.
So it can be a driver mutation, it can be a non-driver mutation. There are tumors in which this is a driver mutation, and there's, in fact, I think it's a phase 3 study at the moment, the Meteor study, which is a PRIMT5 specific inhibitor, and there are other treatment options in development. As well.
I think it will be the final question, because it induces sort of a gain of function.
Yes, the activity.
Is there any, I don't know, attempts to block this enzyme in the treatment?
Yes, the inhibitor which I mentioned, it's a small molecule. It does exactly that. Yes, and there are some preliminary results on one of our collaborators on the structural change with the mutation generates, and they are working on to figure out specifically how. Thank you.
I see no more questions. So thank you very much for your presentation.
Thank you.
And now I would like to invite Grzegorz Procyk, the winner of cardiology and cardiac surgery session, with presentation about sex differences in acute pulmonary embolism patients treated by embolism response team, a multi-center retrospective cohort study.
So first of all, thank you very much for having me here. It's a very great distinction for me. Ladies and gentlemen, great scientific jury, my name is Grzegorz Procyk. I am fourth-year medical student at the Medical University of Warsaw, and I have a great honor of presenting to you the results of our study investigating sex differences in acute pulmonary embolism patients treated by a pulmonary embolism response team. Pulmonary embolism is a serious cardiovascular condition when a blood clot closes an artery in the pulmonary circulation. It leads to a dysfunctional perfusion in the lungs and, in more severe cases, to the death of a patient. Patients at high risk of early mortality require special care and a multidisciplinary approach. It is why a pulmonary embolism response teams were created over a decade ago. CELSAT is a pulmonary embolism response team that functions in Warsaw. It comprises 3 medical centers, and this is Medical University of Warsaw, Bannacha Hospital, European Health Center Otwock, and Medicover Hospital. And the team consists of specialists from different fields. They are available on call 24 hours a day. So during the literature review, I found a couple of papers about sex differences in pulmonary embolism patients. But I found no research about sex differences in pulmonary embolism patients treated by a PERT. I guess it's mainly due to a short existence period of this structure. This is why we aimed to analyze sex-related differences in baseline characteristics, applied treatment, and prognosis of acute pulmonary embolism patients treated by a PERT. In our study, we have included 235 patients diagnosed with pulmonary embolism between September 2017 and December 2021. Patients were hospitalized in any of the 3 participating centers, and we obtained medical data from medical records, and then we analyzed it with appropriate statistical software. Let me start with the age of patients. Hospitalized women were older than men. I have also decided to present you the histograms of age distributions of patients because I find it interesting observation that in men, age was normally distributed, while in women it was not normally distributed. The risk of early mortality was assessed according to the European Society of Cardiology guidelines, and we found no differences in risk classes distribution between the sexes. We assessed also several symptoms on admission, including such as dyspnea or chest pain, and the only one that differed between the sexes in our cohort was cough. It was more common in men, which seems justified by smoking, which is also more common in men. We evaluated over 20 risk factors, and only 2 of them differed significantly between the sexes. The first one was smoking, and it was more common in men, as I mentioned earlier, while the second one was hormonal therapy, more common in women. Pulmonary embolism severity index, in short PESI, did not differ between the sexes. Also, pulmonary embolism severity classes distribution was not different between men and women. We have decided to assess also the need for admittance to intensive care unit, the need for intubation, and the need for the need of use of extracorporeal membrane oxygenation. And it appeared that women were more commonly intubated than men. In terms of laboratory findings, we assessed troponin and NT-proBNP levels, while in terms of imaging findings, we assessed right ventricle dysfunction assessed in transthoracic echocardiography and right ventricle enlargement assessed in computed tomography. None of these parameters differed between the sexes. An interesting observation regards deep vein thrombosis, because proximal deep vein thrombosis was more common in men. However, this observation applied only to proximal and not to the total one. It was on the edge of statistic significance. We also assessed the distribution of pulmonary embolus, and there was no difference in the distribution of pulmonary embolus distribution between the sexes. The most commonly applied treatment was anticoagulation alone, and followed by systemic thrombolysis. We found no difference in any of the treatment options, including also interventional ones, between men and women. We assessed drugs used in anticoagulation, and low molecular weight heparins appeared to be more commonly used in men than women. However, this observation applied only to the full dose of heparin and not to the reduced one. In terms of interventional treatment and different options of interventional treatment, there was also no difference in the frequency of use between men and women. Last but not least, we also assessed the overall survival of our patients in a 5-year observation period, and it appeared that there was no difference in overall survival between men and women. So, to conclude very shortly, as I have presented you, men and women have much more similarities than differences, at least in terms of pulmonary embolism. And I believe that we scientists should report not only statistically significant results, but also when we find no differences, because it is the only way to fight over the publication bias. So at the very end, I would like to thank the whole team. Unfortunately, I didn't have the photo of the whole team because there were so many people. So I would like to thank my tutors and all the professors who supervised us, and of course all my colleagues without whom it could not have been done. So thank you very much.
Thank you for the presentation. Now it's time for the questions and discussion. Are there any questions from the jury or the audience?
Yes, first of all, congratulations for this very interesting and excellent study. I have some questions. The first one, maybe have you looked at differences in cancer? Were there any differences in cancer incidence and of course at causes? For example, thrombophilia incidence was similar. How it was assessed? Could you comment on this?
Okay, so thank you very much for this question. Indeed, the first research that we made was about baseline characteristics, and then there was secondary research, and personally I took the sex differences in this population. However, we also assessed differences between oncological and non-oncological patients, and the main, I guess, the main observation, the main result, conclusion was that there had different survival rates.
And by the way, the observation was done in a structuralized way. I mean, you show some differences in the incidence of deep vein thrombosis. Does it mean that all patients underwent ultrasound examination looking at or looking for deep vein thrombosis?
Thank you very much for this question. Unfortunately not. It's also one of the limitations of this study, because it's not so commonly performed, especially in the centers. It's not so commonly used. However, we decided that if patients did not have symptoms of deep vein thrombosis, then it was, and we supposed that that's why it was not performed. So then we suppose that it's not. That there was no thrombosis in deep veins. However, of course, it may be biased by this risk factor, by this factor. And I found also in the literature a paper from 2018, I guess, and they also assessed different thrombosis incidence and the differences between proximal and distal. And they had it was a meta-analysis of 20,000 of patients, and there they found that proximal deep vein thrombosis was also more common in men. However, they find that distal deep vein thrombosis was more common in women, and we didn't find it.
Okay, thank you for this very nice presentation and research. So how can you comment on that women were more often endotracheally intubated than men? And what is your comment on your future work with this topic? I mean, how would you plan your future investigation?
Thank you very much. So answering your first question, I also asked this question to myself and I made some research, but I found no answers. So it's really also a mystery for me still. But I found that, for example, interventional treatment in one study from a Mayo Clinic, it was more commonly applied in women. So maybe it's some kind of rationale, but I'm not sure about it. And answering your second question, I think that we are planning to expand the observation period, that's first, and also to include more patients, but it requires, of course, time because cells that functions from 2015, I suppose.
I am a surgeon and not a cardiologist, but I am very curious. Why is that important? Do you want to change the either diagnostic or treatment based on sex? Why is that important?
Okay, so thank you very much. So the first research that I actually did about this was the impact of different risk factors on the risk of in-hospital mortality. It's quite similar to what PESI scale assess, but not the same. And there I found that sex did not affect the mortality, in-hospital mortality. However, it is in PESI scale, and it increases this risk of 30-day mortality. This is why I decided to compare in our population, to compare men and women, and possibly find other differences between them, and to evaluate if this maybe some calculated scales should be updated, because we base on them when we make our decisions in applying treatment. So maybe that's why, because if sex should be take into consideration when choosing treatment option, because if there are some differences, it definitely should be.
Okay, thank you for the discussion. The next presenter is Disha Kashvani with a paper entitled Changes of ACE2 related MAR 200B3P expression over time is a predictive factor of long hospitalization for COVID-19 in silico machine learning and validation analysis. So, Disha, the floor is yours.
Hello everyone, my name is Disha. I'm a 6th-year medical student at the English Division of Medical University of Warsaw. Very honored here to be presenting our paper in terms of ACE2-related networks regarding microRNA expression level changes, which is a predictive factor for long-term hospitalization in COVID patients. So in general, to just give you a brief introduction, microRNAs are part of non-coding RNAs that were believed to have not major function, but then over the years, recent studies and analyses have confirmed their role in different procedures of the cell in terms of thrombosis, microvasculature, and I think this is how they were related with COVID as well, because the ACE2 network that is the receptors based on different parts of that COVID patients became that entry point of the microRNAs within the patient that was hospitalized. So that is the basis of our study. We had the previous bioinformatic analysis, which we utilized to identify what our network of route of entry will be, and we also understood which microRNAs will be the ones that we will be using to understand their analysis levels in that blood of the patient. So the underlying pathophysiology correlates with the COVID patients because the microvasculature is thrombotic and coagulative in its nature, which is how the microRNAs correlate with the circulating levels. So coming to the study, our aim was to identify those microRNAs which we saw previously from our bioinformatic analysis in literature. And we wanted to validate those microanalyses. So now we have a sort of literature base to understand these are our existing biomarkers we want to look at. We correlated them by analyzing blood samples in hospitalized patients and matched controls through PCR validation. So generally, this is the design of the study. We had 79 hospitalized COVID patients and 32 matched controlled. So the samples that were taken, they were at different time points. We had samples on the day of admission, 7 days after, and 21 days after. And that's the whole idea, that the microRNAs were determined for the qT-PCR analysis and further statistical analysis to relate those in the different time points as well. The patient characteristics, I understand, are rather well matched with the hospitalized COVID patients and the controls. As you can see with the p-values, they're all relevant and quite, I would say, equally distributed. And this is just a bioinformatic analysis to understand those microRNAs that we chose. So I think to understand the general point of view, these are the 5 that we chose to look for the blood sample. The results are as such. I think this is the interesting part, to see what we found out to validate in that analysis. These were the 4 different microRNAs that we found. So as you can see, microRNA 26, for example, and 10B had rather similar levels at admission, 7 days and 21 days after, in comparison to healthy controls, whereas microRNA 124 had higher levels in compared to healthy individuals. And the interesting one to see is microRNA 200, which had decreasing expression in compared to healthy individuals, with at admission having similar and 21 days after admission having lower expression. And I think this is one of my favorite points to reiterate and emphasize, that this is what leads to the future door opening, that this microRNA contributes to the prognostic potential because it correlates with the increased hospitalized stay. You have a higher baseline, higher expression with patients that stayed less than 21 days, like we saw before, whereas over 21 days or death had lower expression, and that contributed with that hospitalized length of stay, as we can see in our ROC curve analysis, that this was a relevant result point. And I think this is also important to reiterate that we did further logistic regression analysis to further confirm our data, because it's not enough to just end at one point and confirm the data. So we wanted to perform further validation studies. So we contributed to a logistic regression analysis. Here we found that, as mentioned before, the lower microRNA 200 expression, for example, compared to diabetes mellitus as an independent factor for the COVID-19 patients, also had a relevant 5-fold, 4-fold time increase. So I think this shows the relevance of it in clinical terms, that diabetes mellitus and the microRNA expression are independent factors with such high-fold increase that can predict the prognosis of those patients that are admit. So once you can make this into practice, you can see and predict how their future treatment can look like depending on their predisposition. This is also our further disease-related enrichment pathway analysis. So what's important here to see is that microRNA 200, the one that was validated in the previous idea, is related to myocardial ischemia, for example, or arterial hypertension in those patients. So it contributes to further comorbidities as well. It's a very validated and related disease pathway. So just generally to conclude the idea that these microRNAs serve as prognostic and diagnostic biomarkers, with being independent risk factors of other comorbidities, contributing to increased hospitalized length in stay, further contributing to prognosis. And to understand the idea of biomarkers in general in terms of the novelty of these diseases, the impact of them is kind of beyond of just those circulating levels. You can, we've identified them at these different time points, and they serve that validity because of those different time points. Just to reiterate my contribution to this study, I was the student principal investigator of the mini grant, which was the starting point of this idea. It was not part of the blood sample collection, but part of the laboratory work. So we did the RNA isolations, the PCRs. I also learned the fundamentals of the statistical analysis with the trustee. Also part of the abstract preparation, the manuscript, it's currently submitted in the Journal of Medical Genetics, and also principal investigator of the NN grant from the ministry. So we'll hopefully be presenting this work at the American Heart Association next month. So thank you very much.
Thank you, and now we can open the discussion.
Okay, thank you very much. Nice study. Well, first, you said that these mirrors are ACE2 related. However, activation of ACE2 causes the generation of Ang17, and which acts on MAS receptor, causing vasodilation and anticoagulation, inhibition of coagulation. Probably it's more related to the interaction of coronavirus with the endothelial cell itself, not maybe directly related to ACE2 pathways, because ACE2 is only a receptor for all coronaviruses we know. So that's the first question, maybe more common than a question. But the question is, over the clinical course of the infection, you notice the changes in MRI 200 levels. Maybe it's related to the treatment, because those people are treated, and the treatment is different depending on the week of the disease, okay? Usually you up-titrate the treatment, adding additional drugs. So for example, I guess at the third week, people are at ICU, probably mechanically ventilated, treated with tocilizumab or other drugs. And also they develop multi-organ complications. So how can you tell these changes may be related to, for example, multi-organ failure, like, I don't know, renal failure, respiratory insufficiency, and so on?
So first of all, thank you for the question about the ACE2. About the ACE2 networks, the ACE2 receptors are the entry pathway of the virus into the body. So they're mostly located on the nose, for example. That's how they're related with the sort of idea of the circulating microRNAs, that's the entry point. And in our bioinformatic analysis, we found that those were the network interactions. So when I saw the disease, when I showed the disease enrichment pathway, that is how we correlated these networks, because in our statistical analysis, they showed a relevant and significant correlation because of those receptors. And of course, there's different factors that play into the whole COVID disease manifestation, but these microRNAs were just generally found to be interacted with the thrombotic and hypercoagulable state, because the disease is a multifaceted inflammatory process that increases the correlation of these microRNAs circulating. And about the second question, which was about the disease course and the process of treatment and how we predict how those patients progressed. So we had the 3 different time points where we collected the blood samples, and in general there were some patients that, for example, were discharged before or after 21 days, and then there were also some patients who also died. So for our second for the third time point, we had the 21 days or death in our ROC curve analysis, and I think that's what was relevant to see in terms of an independent predictive factor, that we incorporated the patient characteristics which they were predisposed to. For example, they had asthma or some other comorbidities, and we also understood the correlating independent disease factors. So I know that this is a limitation because we have our small sample size and limited factors that we assessed for, but the logistic analysis statistically proves that one microRNA biomarker is statistically relevant.
Okay, thank you for a very nice study. So I would like to ask you, we have discrepancy between control and investigated group. Could you comment on it? Was it influencing the results of your study, and what was the distribution of the data?
So I understand that the question is asking about how the difference is in the results between the controls and our COVID hospitalized patients. In general, we can see that the p-values of the control and the patients, depending on which microRNA we look at, is different. For example, the microRNA 200 that was chosen in terms of the statistical analysis has been statistically significant between comparing the control and the patient at 7 days after admission and control and 21 days after admission, which is what led to us using that for this logistic regression analysis. So I think in that way, this was rather helpful that the control patients were very well gender and different comorbidity way matched. And I think that we can also see in the patient characteristics. All the p-values show that these distributions between both the patient data sets were very well matched, and that contributed to our significant result in the study.
Congratulations once again for a very nice study. If I get it right, your main finding is that this microRNA has a prognostic significance regarding the length of stay of hospitalized patients. But the thing with the statistics is what you get out depends what you put in the analysis. So what my biggest doubt is whether we really need to assess the microRNAs. So did you check whether including the microRNA is, for example, better than a simple analysis of C-reactive protein, which is probably also related?
So that would be a comparative correlation analysis to check which other factors are related to our microRNA. The idea of why we chose the microRNAs is because generally this is our area of interest. They are non-coding RNAs that can eventually serve as a very simple and easy biomarker. CRP, for example, can be increased in various different inflammatory states. Of course, it is a predictive factor of COVID, for example, because it is an inflammatory disease. But from our findings from the bioinformatic analysis, the microRNAs can be specific. So CRP is a general reactive protein, but microRNA, for example, 200, can be defined as a specific biomarker for this one disease, which is how it can very specially relate in terms of its disease processes and alternate in expression. So I think, of course, the idea to choose the microRNAs is depending on the existing data we have, which is why we did that bioinformatic analysis. We reduced to 5 microRNAs that we want to use, and we sort of moved on from that point of view. There were the volcano plots of hundreds and thousands of microRNAs, so we won't assess for all of them. But of course, there's a narrow down method that we would use.
Okay, thank you for the discussion and your presentation. Our next speaker will be Wiktoria Grycuk, the winner of internal medicine session, with her presentation, proenkephalin levels and its determinants in patients with end-stage kidney disease treated with hemodialysis and peritoneal dialysis.
Okay, so good afternoon, dear jury and dear fellow students. My name is Wiktoria Grycuk. I represent the Students Research Group at the Department of Nephrology, Dialysis and Internal Medicine at Medical University of Warsaw. Today I am pleased to present you our study, proenkephalin levels and its determinants in patients with end-stage kidney disease treated with hemodialysis and peritoneal dialysis. So to begin with, clinical research on novel biomarkers of kidney function has been very intense in recent years and has identified proenkephalin as one of the most promising markers for the early diagnosis of acute kidney injury. Proenkephalin is a precursor molecule of enkephalins, endogenous opioid peptides. However, unlike enkephalins, proenkephalin remains stable after collection, which potentially makes its use feasible in clinical practice. Previous studies have shown that proenkephalin correlates strongly with glomerular filtration rate, the GFR, and that higher levels of proenkephalin predicted not only acute kidney injury, but also future decline of the kidney function as well as mortality in several settings. More recent trials have also implicated its relation to cardiac status, as higher levels of proenkephalin were independently associated with poor outcomes in patients with heart failure. However, before any biomarker is implemented into clinical practice, it requires validation in different settings. And to our knowledge, there have been no studies to date which evaluated proenkephalin in individuals with severely impaired kidney function treated with dialysis treatment. So therefore, we aim to investigate proenkephalin in patients with end-stage kidney disease to investigate its correlation with several clinical and biochemical variables, and finally to determine whether proenkephalin can be removed during hemodialysis session. So to conduct our study, we identified adult patients undergoing dialysis treatment in our center between May and June 2022. Amongst them, 66 patients treated with hemodialysis and 22 treated with peritoneal dialysis met the inclusion criteria and were invited to participate in this study. The study was approved by the ethics committee and all participants provided their written consent. From each participant, we obtained plasma to assess proenkephalin concentrations. Blood samples were collected twice in hemodialysis patients before and at the end of the procedure, and at a single time point in peritoneal dialysis patients. The obtained plasma was frozen and stored until assay. Proenkephalin was further assessed by using a sandwich ELISA immunoassay, which used monoclonal antibodies specific to this peptide. For all patients, standard biochemical parameters, including creatinine, urea, estimated GFR, were measured on the same day. Additionally, to check for the cardiac status, patients underwent screening for heart failure, which involved the measurement of NT-proBNP and the assessment of ejection fraction. Statistical analysis were performed by using Excel stats software. The comparison between two groups was done by using Kruskal-Wallis test, and the Spearman-Rank correlation test was used to perform the correlation analysis. Here you can see the basic characteristics of our study group. The median age was 65 years, and there were 41 females enrolled in this study. More than 60% of our patients have been receiving dialysis treatment for at least 1 up to 10 years, and more than 50% of the patients had no or very low residual urine output. Additionally, 24 patients have been diagnosed with heart failure. In this table, you can see some of the baseline values, but notably you might observe that proenkephalin levels did not differ significantly between hemodialysis and peritoneal dialysis group. Likewise, estimated GFR and NT-proBNP were also similar between these two groups. To check for the correlation of proenkephalin with kidney function, we searched for the association of proenkephalin with some of the kidney function indicators, and in this study, no correlation between proenkephalin and urea or estimated GFR were found. Also, we did not find differences in proenkephalin levels among patients with varying degrees of residual urine output. Similarly, we analyzed whether concentrations of proenkephalin in patients with heart failure differ from those in patients without heart failure. And further, we investigated the possible correlation of proenkephalin with NT-proBNP. However, in these analyses, no significant findings were found either. In order to investigate the change in proenkephalin concentration during hemodialysis, we assessed its concentration directly after the procedure. And as you might observe, proenkephalin concentrations were significantly higher in a second sample. And therefore, we hypothesized that the concentration rise might be due to removal of excessive fluid during hemodialysis. However, to further explore these findings, we wanted to compare concentrations of proenkephalin depending on the type of dialyzer used. In general, we divided patients into two groups, patients using high flux membranes, which are more efficient in removing fluids and molecules, and patients using low flux membranes. And as you can observe on these graphs, proenkephalin concentrations were significantly higher in patients dialyzed with low flux membranes. And as these results suggest that proenkephalin might be filtered and removed to a greater degree through high flux membranes, we wanted to check whether these results are not influenced by the differences in residual urine output between high flux and low flux groups. However, no such differences were found, therefore suggesting that removal of proenkephalin might be dependent on the type of the membrane used. So to conclude, this was the first study evaluating proenkephalin in patients with end-stage kidney disease. Our results did not corroborate the results of previous trials in patients with preserved kidney function. Based on these results, we conclude that proenkephalin cannot be considered a reliable marker in monitoring kidney function in individuals with impaired kidney function, especially in those with acute kidney injury who might require treatment with hemodialysis. And finally, further research is required to develop new biomarkers for the early diagnosis of acute kidney injury. Thank you for your attention. I would like to thank to my co-author, Dr. Zuzanna Jakubowska, and to my tutor, Professor Jolanta Moszko, for their help. And I would also like to mention that this was a part of mini-grant project and received funding from Medical University of Warsaw. Thank you very much.
Thank you for your presentation. Let's open a discussion.
Just what do you mean by no active clearance of the molecule in the kidney? There was a statement on the second slide.
Oh, I meant the active secretion through the tubules. Maybe it was a mistake on the slide, but I actually meant the active secretion through the kidneys, like in the case of creatinine, which is also actively secreted through kidneys.
So it's not absorbed, not secreted, not metabolized within the kidney.
Yes, exactly. That's why it was considered a very suitable marker.
Thank you for this excellent presentation. You mentioned NT-proBNP.
Yes.
I have two questions. The first one is, how did you diagnose heart failure? Was it based on NT-proBNP or other data? And the second, what is the relation between NT-proBNP and renal function?
Okay, so answering your first question, the diagnostic criteria for heart failure were, apart from clinical and clinical symptoms and signs, all patients all patients have been meeting a cardiologist, and all patients had echocardiography. And most of the patients, it was available for approximately 56 patients, had NT-proBNP measured, but it was not considered like a principal criterion for the diagnosis of heart failure. So it was basically echocardiography and either decreased ejection fraction or other abnormalities.
So I understand that it was based on heart, let's say, abnormalities. Not all heart abnormalities are necessary or equivalent of heart failure. One may have late ventricular hypertrophy and may not have heart failure.
Yes, of course. So you mean heart failure with preserved ejection fraction, right? Okay.
They did have a heart failure. We did the echo study.
Yes, it was performed by cardiologists from this hospital. And answering your second question, what's the correlation of NT-proBNP with kidney function? It has been found that the concentrations of NT-proBNP rise with decreasing glomerular filtration rate, and the concentrations of NT-proBNP are increasing in subsequent stages of chronic kidney disease. So basically, it is explained through hypervolemia in patients treated with hemodialysis and peritoneal dialysis. Additionally, there's a hemodynamic stress, which acts on the levels of NT-proBNP as well. And yes, I guess that's it.
Thank you for the discussion. Our next speaker is the winner of Lifestyle Medicine and Public Health session, Anastasia Shvarok, with a paper entitled Assessment of Risk of Developing Cardiovascular Complaints Among Ukrainian Students and Situational Anxiety Level During the Martial War.
Good afternoon, esteemed colleagues, Presidium and jury. Thank you for organizing the Congress and inviting us to participate. Today I present you the topic, Assessment of the Risk of Developing Cardiovascular Complaints among Ukrainian Students and Situational Anxiety Level during the martial law. And today I introduce this work not only like an author, but also as a human, who has been living under wartime conditions for over 1 year and who is here today, thanks to you. So, we remember the 24th of February 2022 as the day when our lives were split into two different parts because of Russian Federation's intervention in the territory of Ukraine. The population of our country has been under chronic stress for more than 1 year. Youth is thought to be the most enduring population category. However, their physical and mental resources are not unlimited. The increase in the level of state anxiety causes destabilization of the organism, and cardiovascular complaints appear as a result. The aim of the study was to assess the risk of developing cardiovascular complaints among Ukrainian students and the level of situational anxiety during the martial law. So, as the task was to assess the existence and magnitude of the risk, various research methods were used, including anamnestic, computational, and statistical ones. The information was collected through an anonymous online survey, which consisted of 2 sections and was used for further analysis. The first section of the questionnaire contained 20 statements from the Spielberger-Hanin test, according to which students assess their condition by choosing a number from 1 to 4, and questions about the occurrence or exacerbation of previous complaints from the cardiovascular system from the 21st of February 2022. In case of a positive answer, respondents were directed to the second part of the questionnaire, where their complaints were detailed. A subjective assessment was made regarding the connection between their own condition worsening and the military events in Ukraine. So, the distribution of results was as follows. Out of 123 students, 33 scored a total of no more than 30 points, which corresponded to a low level of situational anxiety. 40 of them scored from 31 to 45 points, which corresponded to a moderate level. And 50 of them, the vast majority, scored 46 points or more, which corresponded to a high level of anxiety, as you see. 2 groups were formed. To the first one belonged students whose level of anxiety remained within the low range, and to the second one belonged students whose level of anxiety was moderately or significantly elevated, with a score of more than 30 points. Both groups include students who reported cardiovascular complaints during the state of martial law in the country and who didn't. So, the result was as follows. 87% of students who reported the appearance or exacerbation of cardiovascular complaints after the 24th of February 2022 subjectively attribute changes in their health to the martial law in the country. To sum up, yes, there is an increased risk of developing cardiovascular complaints under the influence of high level of situational anxiety level in exposed individuals, odds ratio 5.08. The most common complaints include episodes of tachycardia, palpitation, dizziness, pain in the area of the heart apex, shortness of breath during the physical exertion. 87% of surveyed students who reported experience of worsening of cardiovascular symptoms after the 24th of February 2022 attributed these changes to the state of war in the country, affecting their health status. We are thankful to Poland and all countries who support us. Slava Ukraini! Thank you for your attention. I am open to your questions.
I have one question. Maybe I missed. Students that were evaluated, they were medical students or they were students of different, let's say, areas?
Yes. Thank you for your question. Yes, of course, it were different students, not only medical ones.
So maybe you have found some differences between different, let's say, types of studies, including artistic ones or technical studies. Have you looked at these differences in terms of prevalence of anxiety?
Thank you for your question. It will be our future work. We are working on it.
Is there any difference between the distance from the front line and the incidence of symptoms?
Our investigation showed that the level of anxiety doesn't matter because the martial law in the country doesn't matter how distant the student is located. Anyway, air raid sirens, anyway, shaheeds disturb us. So there is no difference how far it is.
Okay, I see no more questions, so thank you very much once again.
Thank you so much.
And now I would like to invite Adriana Maria Peżanowska, the winner of neonatology session, with her presentation, comparison of selected indicators of perinatal care in Poland and Zimbabwe, with special focus on maternal mental health and neonates' birth status.
Hello, ladies and gentlemen. I am honored to present my study, which was conducted in Department of Neonatology and Rare Diseases of the Warsaw Medical University and in Binga District Hospital. Postpartum depression is a common and a serious mental health problem which is associated with maternal distress and negative consequences for the offspring. From the work published so far, we know that the risk factors for PPD are low socioeconomic status, unwanted or unplanned pregnancy, and a severe condition of the baby after being born. This maternal condition has also been shown to have a significant impact on the child's abnormal cognitive and emotional development, as well as disturbance in sleep-wake rhythm. Maternal and neonatal care also has a major impact on the health of the newborn, which varies between highly developed and developing countries that we have compared. The established criteria for our study were the age of the mother between 18 and 40 years old and no previous history of psychiatric treatment. We were able to analyze the data on 951 women from Poland and Zimbabwe. The aim of our study was to compare the severity of depressive symptoms in both countries and to identify the risk factors in both populations. We have also compared the neonatal biometric parameters as well as other circumstances which may have affected the status of mother and newborn. The study was conducted completely electronically using the Kobo toolbox, which allowed us and our colleagues from Africa to assess our process. We have also used the Edinburgh postnatal depression scales, which assess if the mother is at high risk of PPD or not. The newborns were assessed with the Apgar scale and other standard parameters like weight and height. Analysis of the results were performed using the Mann-Whitney test, and the Cronbach alpha test was used to assess the internal consistency of EPDS in both groups. I have also created the survey, which consisted of 3 parts, and the first one was focused on perinatal period, second one on the newborn's status after being born, and the third one on the general mother's health and previous pregnancies. And as we can see, in the neonatal population, the most significant differences were revealed in the mean birth weight of the baby and Apgar score. These results were statistically significant, and also we can see that in Zimbabwe, more babies had severe condition after being born, which was lower Apgar score, which the average score was 7.3, and newborns from Zimbabwe had a lower birth weight. Also, in Zimbabwe, more babies were delivered prematurely. On the other hand, in Warsaw, more cesarean sections were performed. And as for such other methods, in both countries they were used only a few times, of which more often in Poland. Also, as you can see, we have found statistically significant differences in the percentage of women with increased risk of postnatal depression. In Poland, it was 16.23%, which is consistent with other publications published so far for the Polish population. And in Binga, it was 20% more. In the group of women from Zimbabwe with high risk of PPD, we have calculated the incidence of previously mentioned risk factors. And as you can see, even 84% of those women didn't plan their pregnancy, and 55% of them had a baby being assessed to less than 7 points on the Apgar scale. We can see that the standards of perinatal care in Poland and Zimbabwe are different, which may have implications for both the well-being and future development of the child. There's a need for more research comparing neonatal, obstetric, and psychological care in developing and highly developed countries. Our next step is to expand our study group and to develop new guidelines which may be implemented after considering the means and needs of those developing countries. We hope that those standards will help doctors in Zimbabwe in their day-to-day work, and it will improve the somatic and mental health of mothers and newborns. Thank you for your attention.
Thank you very much for your presentation. Does anyone have any questions?
So thank you for a nice study. So what was your input in the study?
So I was responsible for collecting the data in Poland, and I was also a supervisor of this process in Africa. And I'm also one of the authors of the survey which we used in our study.
How did you come with the idea of comparing Poland to Zimbabwe?
Well, at the beginning of a university, I was at the foundation which takes care of newborns in Africa. And later, our professor came up with idea to create a cooperation with this particular hospital from Zimbabwe. And we were really interested in the fact what can be done to improve the healthcare in Zimbabwe and how to decrease the mortality rate in newborns in Zimbabwe.
I see no more questions. Thank you for the discussion. The next speaker is the winner of Obstetric, Gynecology and Perinatology session, Natalia Izabela Śmigielska, with her work entitled Obstetric Outcomes After Gestational Choriocarcinoma Single Center Study. The floor is yours.
Good morning, dear jury, dear colleagues. My name is Natalia Śmigielska, and today I'm here to present to you our study about obstetric outcomes after the treatment of gestational choriocarcinoma. So first, a bit of introduction. Choriocarcinoma is an aggressive and really rare form of gestational trophoblastic neoplasia, which is a part of gestational trophoblastic disease. To better understand this connection here, we've made this diagram. So as you can see, in general, gestational trophoblastic disease is divided into two basic groups, premalignant forms and malignant forms. All the malignant forms are marked here with red flags. So they create a common group, which is called gestational trophoblastic neoplasia. As you can see, the numbers in brackets indicate the incidence of each tumor per 1,000 people, and choriocarcinoma is one of the rarest here, and this is what we focus on today. The incidence of choriocarcinoma is estimated to be around 1 in 40,000 pregnancies in Europe. And what is more interesting, it most commonly affects women of childbearing age. The management of choriocarcinoma is based on multi or single drug therapy, although some patients require some additional therapy like hysterectomy or radiotherapy. So the main issue here with all these types of treatment is that they most significantly affect women's fertility. Patients are stratified to receive those treatments by using a FIGO prognostic scoring system, and based on how many points they get, they are classified into a specific group based on which we can select the best possible type of treatment for them. As you can see, many factors are being considered, including age, interval between pregnancies, and resistance to chemotherapy, and many more. Women with scores from 0 to 6 are at low risk of developing resistance to chemotherapy, and because of that, they are initially given single drug therapy, so it's methotrexate. And women with scores of 7 or higher are at the high risk of developing resistance to chemotherapy, so they are initially given multi-drug therapy. On the other hand, women with scores above 12 are at a higher risk of early and late death, so they often require some treatment modifications to reduce those risks. In general, patients with choriocarcinoma are observed only until they are cured from their oncological disease, so we have very limited data on their obstetric outcomes after that period of time. And basically this is why we've decided to conduct this study to evaluate obstetric outcomes after the treatment of choriocarcinoma. Of course, keeping in mind that curing a patient is our main goal, we must not forget about high quality of life and psychological well-being of our patients. So, in our study, we've collected the data from 18 patients treated at Maria Skłodowska-Curie National Research Institute of Oncology in Warsaw between 2000 and 2020, and entered the data into the database. Prior to these patients meeting several criteria, like histopathologically confirmed choriocarcinoma, like they all underwent a chemotherapy, and were below 40 years old. Of course, hysterectomy was disqualifying criteria for our study. Then we've analyzed shown factors and tested whether there is or there is not statistically significant relationship between any of these factors and whether the patient became pregnant. Our patients were from 24 to 39 years old, and we found out that the age was the factor that was associated with the pregnancy success. All our patients who became pregnant were below 30 years old. Other factors such as previous pregnancies, the type of treatment, FIGO staging and FIGO score had no effect on pregnancy success. As you can see, median follow-up was almost 5 years. Ultimately, 4 patients became successfully pregnant and gave birth to a total of 6 perfectly healthy children. The success rate for our patients were 33% when it comes to all patients analyzed, and 40% when it comes to patients only without the disease progression. Unfortunately, 2 patients have died because of disease progression within 1 and 3 months after the diagnosis, and 1 patient had to underwent a hysterectomy about 5 years after the diagnosis. So, heading to an end and conclusion, fertility preservation is an essential part of high quality of life for patients and their psychological well-being after the choriocarcinoma treatment. The results of our study helped identify the chances of having children in young women diagnosed with choriocarcinoma. Our data indicates that these chances can be even up to 40% under certain circumstances, like appropriate age or lack of disease progression. Of course, further studies are necessary to confirm our results on a larger group of patients, and we ourselves intend to continue monitoring and collecting data for the next few years. And that's the plan, and currently we are in the process of some cosmetic improvements on our paper, so we hope to publish really, really soon. Thank you very much for your attention.
Thank you very much, and now it's time for questions and the discussion.
You found congratulations on that study, you found a 40% or 33% of pregnancy rate in those patients, but what was the rate of patients willing to be pregnant?
Yes, that's the limit of our study. In the literature, there are differences, and they are closer to these ours 40%, but we did not have the possibility of asking this question. So it is a plan for the future for sure.
Your study is spanning 2 decades of observation.
Yes.
In medicine, 2 decades is a huge, huge period of time in terms of access to different methodologies. And in particular, in oncology, referral to, for example, surgical treatment, I guess, I'm not an expert, but I guess that over 20 years, it has changed tremendously. So what is the effect of time on your results? What do you think?
Thank you. I'm actually not sure what is the effect. I mean, I don't know what's going to be, what the results are going to be in, for example, next 20 years. But when we've analyzed it and we've decided to put that into our presentation and came here to show it, we've compared it to the literature that's known right now in the world, and the results are really similar, and yeah. Thank you.
Do you know for how long FIGO criteria are on the table? For how long already?
For now.
For how long they are on the table? How long, when they were established?
Well, that depends on which FIGO criteria we're talking about. Basically...
I mean, my question was, were they the same 20 years ago and nowadays?
No, they are not the same.
No, they are not the same.
No.
So, okay.
Okay, thank you very much once again. And now I would like to invite Anna Terlecka, the winner of Oncology and Hematology session, with her presentation, Nivolumab neoadjuvant treatment in patients with locally advanced melanoma. The floor is yours.
Thank you. Hello, ladies and gentlemen, esteemed jurors. My name is Anna Terlecka, and today I would like to present to you original research retrospective study on Nivolumab neoadjuvant treatment in patients with locally advanced melanoma. So the current treatment algorithm in locally advanced melanoma, as you can see in the highlighted area, is first a wide excision and then targeted therapy or immunotherapy as an adjuvant treatment post-surgery. Our work is on neoadjuvant treatment, so treatment pre-surgery with immunotherapeutic agents such as nivolumab. As you can see in the figure on your left, there are several benefits to it. First of all, If you apply immunotherapy when the tumor is still present in the organism, lymphocytes T are activated. And then, later on, they can be more diverse and there is more of them. Second, you can see on your right that if there are micrometastases present and you apply immunotherapy pre-surgery, there is a chance for activation and elimination later on, which is not the case in adjuvant treatment. So, as you can see on your right, on the graph, prognosis in patients with locally advanced melanoma is not great. In stage 3, 5-year overall survival is 60%, and in stage 4, it's around 20%. And preoperative treatment may increase chances for radical resection and result in better long-term disease control. So our study objective was to assess the effectiveness of nivolumab neoadjuvant treatment in patients with locally advanced melanoma. Enrolled were patients from the National Institute of Oncology who started their treatment between August 2016 and August 2021. They received neoadjuvant nivolumab immunotherapy and were later operated. Nivolumab treatment lasted for at least 8 weeks pre-surgery and could be continued post-surgery. And we performed diagnostic imaging every 3 months. The average age of the participants was 58 years old, and there was an equal number of males and females in the group. In the first part of my results, I would like to mention the staging of the disease. When it comes to the C43 type of the melanoma, most cases were skin melanomas with 40% on the upper lower limb or the back. As you can see, the T and N parameters varied quite significantly, with half of the patients having T4 melanoma, so more than 4 millimeters of infiltration. And below in the table, you can see the location of resected lesion. It varied quite significantly. There were lymphadenectomies in around 1/3 of the cases, but there were also sites such as maxilla, abdomen, or liver. So we achieved negative surgical margins in around 70% of cases. When it comes to the ER1 and ER2 surgical margins, it's worth mentioning that these patients in the primary staging had T4 infiltration. 90% of the patients from the group didn't have any radiological signs of tumor post-surgery, and only 15% of patients experienced surgical site recurrence. One patient from the group only experienced any surgical side effects, and it was delayed wound healing. When it comes to the outcomes of the systemic treatment itself, so the treatment with nivolumab, 1/3 of the patients experienced adverse effects of neoadjuvant treatment, and 85% of the patients from the group continued the treatment post-surgery. Only 3 patients withdrew from the treatment due to toxicity post-surgery. Here you can see the Kaplan-Meier graphs. It's worth pointing out that the 1-year overall survival was 95% and 2-year overall survival was 85%. There is no available study right now on nivolumab neoadjuvant treatment. It's really a novel area of oncology, but there is a well-known study by Professor Menzies. You can see it on the right. It was on nivolumab and ipilimumab treatment in different doses. Ipilimumab is an anti-CTLA-4 antibody, and normally in adjuvant treatment, the difference between using nivolumab and nivolumab combined with ipilimumab can be even 20% in the event-free survival. We decided to define our event-free survival the same as the authors of this work and compare it. And in our case, it was only a 5% difference. Our event-free survival at 1 year was 75%, and it's quite promising, comparing results to the adjuvant treatment, as I mentioned before. So to conclude my presentation, neoadjuvant treatment with nivolumab may be effective in patients with locally advanced melanoma and may increase chances of a negative surgical margin. It's worth pointing out that these patients should be discussed in a multidisciplinary team with oncologists and surgeons present, and we need more large-scale 3 and 4 phase trials to certify the use of immunotherapy as a neoadjuvant treatment and to compare different agents. You can see on the right, this is the most well-known study on neoadjuvant treatment right now in melanoma. It was published a month ago in the New England Journal of Medicine. And as you can see, the difference between a neoadjuvant adjuvant group and adjuvant group only is very significant, and it's 23% when it comes to the event-free survival. So the most important takeaway from this presentation is to first consider immunotherapy as a neoadjuvant treatment before resection in patients with locally advanced melanoma, and to discuss them in a multidisciplinary team, because it may improve patients' outcomes significantly. And I would like to thank my mentors, Professor Piotr Rutkowski from National Institute of Oncology, Professor Anna Czarnecka, and Dr. Paweł Sobczuk for making this all happen. And thanks to them, I'm here today. So thank you very much, and thank you for listening to my presentation.
Thank you very much for your presentation. Let's open a discussion.
How about BRAF mutations? Were they on BRAF inhibitors, those patients?
6 of the patients had a mutation in BRAF, so 30%. And some of them had BRAF inhibitors post-immunotherapy. I mean, they received another line of treatment later on with BRAF inhibitors.
So they started with immunotherapy first?
Yes, in some cases, yes, they did. And then they received the BRAF-targeted therapy.
So was there any difference between those with BRAF mutation and mutation negative?
Interestingly, I will actually present it at another conference. There is a difference, and in BRAF-mutated patients, the outcomes were better than in patients without the BRAF mutation, when it comes to the immunotherapy only.
I have a short question. What was your contribution to this study?
I read through files of any potential patient who could be included. As you can see, the enrollment period was from 2016, so it was quite a lot of work, because I had to check all the surgical reports, the histopathological reports, and then I collected the data and made a database with these patients. Also I visited the operating theater with the professor a few times. Although I'm not planning to be a surgeon, I wanted to see it firsthand, how it's done, to understand the topic better.
Thank you for the discussion.
Thank you very much.
I would like to invite the next speaker, winner of orthopedics and traumatology session, Bartłomiej Wilk, with his paper entitled Changing the Size of the Anterior Part of the Distal Femur After TKA Affects Knee Flexors Force. The floor is yours.
Ladies and gentlemen, honorable jury, the topic I'm about to present may not be especially eye-catching for the general public, although I hope it will be interesting for you, as it is closely related to everyday challenges of orthopedic surgeons. Total knee arthroplasty is a standard procedure in the treatment of knee osteoarthritis. It is well proven to be beneficial when it comes to reducing pain and increasing the quality of life of the patients. Nevertheless, up to 20% of the patients remain unsatisfied after the procedure. When comparing it to the satisfaction rate after total hip arthroplasty, which is estimated to be as high as 95%, we can clearly see the discrepancy. This may be caused by various reasons. However, the most important information for us is that we still have to search for the new improvements in total knee arthroplasty procedure. One of the factors that is really important in patient satisfaction after total knee arthroplasty is the painless range of motion, well proven to be crucial. Even this aspect alone is broad and can be approached in numerous ways. We decided to concentrate on the biomechanical part and explore the relation between the femoral component placement and the knee flexors and extensors muscles force. At first, it may seem obvious. If we move the femoral component anteriorly, the tension increases in the extensors mechanism and decreases in the flexors mechanism. And if we move it posteriorly, the relation inverses. Does this mean that in every patient, in the aspect of muscle tension, the optimal implant placement is the same? A closer look at the preoperative radiographs may help us to answer that question. This comparison shows that the distal femoral anatomy varies in every patient, causing different preoperative setup. That is why we decided to check how does the relation of preoperative femoral anatomy to postoperative femoral component implant placement affects knee flexors and extensors muscles force. To do so, we took a group of consecutive patients who underwent total knee arthroplasty, and on the pre- and postoperative radiographs, we measured posterior condylar offset, or PCO for short, defined as the distance between the line tangent to posterior femoral cortex and a parallel line tangent to posterior femoral condyles. Next, the posterior femoral cortex, posterior femoral offset ratio, or the PCOR for short, defined as the ratio between PCO and the distance between the line tangent to the anterior femoral cortex and a parallel line tangent to the posterior femoral condyles. And finally, we measured the parameter we called the anterior femur index, defined as the distance between the line tangent to anterior femoral cortex and a parallel line tangent to the most anteriorly placed point of the distal femur. In each of these parameters, we calculated the difference between preoperative and postoperative value, calling it d delta. Additionally to those measurements, we examined peak and average flexors and extensors muscles force using the active force dynamometer. We performed the distribution check using the Shapiro-Wilk test, which has proven normal data distribution in all the parameters. And knowing that, we examined the gathered data using persons and T-students tests. When it comes to the results, we found out that neither the difference in pre- to postoperative PCO nor the difference in pre- to postoperative PCOR did not have any significant effect on the flexors or extensors muscles force. Although the examination of pre- to postoperative change in the anterior femur index brought us some more promising results. The presented table with Pearson's correlation coefficient depicts that the pre- to postoperative change in anterior femur index does not significantly correlate with peak or average extensors muscles force, so you can see it on the right side, and that it significantly negatively correlates with the average and peak flexors muscles force. You can see it on the left side. Rephrasing it into a conclusion, our study proves that by increasing the difference in the size of the anterior distal femur after total knee arthroplasty, we decrease the force of the flexors muscles. This is worth consideration regarding the postoperative results and patient satisfaction, which, as I mentioned, is closely related to the painless range of motion. But primarily, the results should remind us that to obtain the optimal postoperative muscle force, we have to individually choose the implant placement for every patient. I hope that the study brought some attention to the aspect of knee biomechanics, which in my opinion still needs to be further explored. Thank you very much.
Thank you very much, and now I invite you to the discussion.
Okay, I have to assure you that we are very much interested in this topic because all of the members of the juries has both knees. So that's the first. So and the second, you started from the statement that patients are not satisfied. So do you have any data? No, I do remember that. Do you have any data that, for example, there's a difference in, I don't know, quality of life after the surgery depending on the anatomical differences?
Mm-hmm. That's a great question. The reason why we decided to take a look at this topic, this particular topic, is that there is a huge amount of articles that describe that the operation is great. We do great work putting the implants in the patients. But there are few articles that would admit that maybe for the last 10 years we've been doing it a bit wrong, because there was this dogma that there is the optimal placement that we aim on, and not many authors took into consideration this option. This is quite novelty to my knowledge. So I am not aware of any articles that would concentrate on this aspect alone.
What was your part in this project?
Okay, that's a great...
the students' part, also your colleagues.
Okay, so to be fair, I'll start with my colleagues to describe what they have done. So Dr. Maciąg helped me with methodology, Dr. Grzegorz, to be precise. Dr. Bartosz Maciąg helped me with the vision, and he was my tutor in the study. Dr. Łapiński and Dr. Świercz performed tests with the dynamometer to assess the muscle force. I performed the radiological findings, as well as the initial selection of the patients for the study.
Okay, I see no more questions, so thank you very much for your presentation once again.
Thank you.
Our last speaker will be Adrian Balcerzak, the surgery session winner, with his research, surgical analysis of aberrant hepatic arteries, cadaveric pilot study.
Ladies and gentlemen, dear jury, my name is Adrian, and today I would like to stir the water on the topic of the anomalous vascularity of the liver. This is a surgical analysis of aberrant hepatic arteries, cadaveric pilot study. The standard nutritional vascularization of the liver comes from the abdominal aorta through the celiac trunk, the common hepatic artery proper, then the right and the left hepatic arteries to the liver lobes. In this photo, you can see the vascularity of the liver that is seen during an anatomical dissection and stays in similarity to what a surgeon sees during an open surgical procedure. But when we are talking about a vascularization of the liver, we have to talk about the aberrant hepatic arteries. This term consists of two minor terms, the accessory hepatic arteries and replaced hepatic arteries. Accessory hepatic arteries are originating from a variant trunk and are supplying a portion of a liver with blood alongside with other vessel. The replaced hepatic artery is the same, however, it's only source of the region of the vascularization. The importance of those arteries are no mystery to anyone due to the fact that the variation in the arterial blood supply to the liver occur up to in 15% of the donor livers, and the aberrant hepatic arteries are detected in 17% of preoperative visceral angiograms. The failure to preoperatively recognize those anomalies can lead to a serious complications, such as the vascular compromise of the liver ischemia, and in patients with chronic liver disease, even liver lobe necrosis. The complication rate for vascular surgery remains at the very alarming 42.4%, with 20% of the surgeries associated with major complications, and more than half of them considered avoidable. So, where is the problem? The detailed preoperative evaluation or radiological examination is proven to be needed to localize aberrant hepatic arteries. Also, multiple studies advise for such an evaluation using the computer tomography images. However, current aberrant hepatic arteries classifications are either too extensive or incomplete and provide little to no clinical differences between the types. There is also a more modern approach to this matter, and there are authors and researchers that try to provide us a type for every clinical scenario. However, this leads to a situation where we have 13 types or even 26 types classifications. And even though we have 26 types of them, there are still articles reporting that there are some vascularities, some anomalies that are not included in any of them. So to sum up the problems associated with those classifications, they provide little to no clinical difference between the types, are too extensive for everyday clinical use, and often are not adequate to the possibilities and, more importantly, the needs of the preoperative assessment. So the aims of our study were to assess the occurrence of aberrant hepatic arteries, to compare it to its incidence in intraoperative studies, and more importantly, to introduce a new, simplified, and clinically highly useful classification of hepatic vascular variabilities. I performed an anatomical dissection of 54 cadavers fixed in 10% formalin solution with no signs of surgical interventions in the area. During the creation of the classification, I took into consideration the clinical significance of the origin of aberrant hepatic artery and tried to fit it into the classification itself. And as a result, I emphasized that the aberrant hepatic arteries are present in more than 25% of the cases, with majority of them observed in females and some of them in males. Also, the incidence during the anatomical dissection was greater in comparison to the observations in the other types of the study, so intraoperative studies and CT scans. Coming to the aberrant hepatic artery classification itself, we divided the abdominal cavity into 4 quadrants, representing the area of the aberrant hepatic artery origin. The intersection of the line, so the point 0, was established at the origin at the superior mesenteric artery. Different aberrant hepatic arteries origin types were assigned to the quadrants based on the topographical location. And on the slide you can see how did we manage to divide the abdominal cavity, and now I will analyze one by one the quadrants. So the first quadrant present in majority of the cases, almost 43% of the cases, with possible origin of the aberrant hepatic artery at the celiac trunk, common hepatic artery proper, left and right hepatic arteries, and right gastric arteries. This region is associated primarily with operations on the liver and bile ducts. The second quadrant, present in 21% of the cases, with possible origin at the left gastric artery, splenic artery, and left gastroepiploic artery, associated primarily with operations on the stomach and spleen. Third quadrant, not observed during this study and extremely rare in the literature, with possible origin of the aberrant hepatic artery at the left gastroepiploic and right gastroepiploic arteries. This region is associated with primarily operations on the stomach and the intestines. And fourth quadrant, present in nearly 36% of the cases, with possible origin at the superior mesenteric artery, the inferior pancreatoduodenal artery, and right renal artery, is primarily associated with operations of the duodenum and pancreas. To draw some conclusions from this research, I emphasize that the aberrant hepatic arteries are relatively common vessels characterized by great variability in their origin. Also, the incidence of the aberrant hepatic arteries was observed to be greater, higher, during anatomical analysis of cadavers in comparison to the observations in other types of the studies. So there is a possibility that the aberrant hepatic arteries are underdiagnosed for some reason. Also, this is the introduction of new, structured, and simplified anatomical classification that seems to have more clinical implication than the previous systems. Thank you for your attention, and please do not hesitate to ask any questions.
Thank you for your presentation. Now, let's open our last round of discussion.
Okay, if I may start. Congratulations. I do appreciate your personal contribution to this project because, as I understood, you did all these analyses by yourself, anatomical dissections. But I noticed there's a tremendous gender difference in the incidence of aberrant arteries. Why is that? You have any idea, explanation why there's such a gender difference?
So in my study, which consisted only of 14 of the aberrant hepatic arteries, the results are not completely reliable. However, there are bigger data studies that suggest that there is a difference and women are more likely to have an aberrant hepatic artery. It's also, it has to be done that the accessory hepatic arteries and replaced hepatic arteries are also in differences, and accessory hepatic arteries can be more frequently seen in males and the replaced hepatic artery in females, and those are the more important ones. So this amount of data does not provide us with a reliable conclusion. However, it remains in general trend that the women are more likely to have one of those arteries, and the reason why that is, I don't know, and I do not know if there is an explanation in the literature. I did not read about it.
When it comes to other parts of the arterial tree, are there also such gender differences?
So, from my experience,
in the brain, in the heart, definitely not. But I don't know. Maybe in some other visceral arteries.
Yes, from my experience, which is obviously limited, but I managed to also did a research on the superior mesenteric artery and the inferior mesenteric artery, and in those arterial systems there are significant anomalies, and women were also more prone or more likely to possess the type of the anatomical anomaly, which is in the contrary to the most common one. So the one that we are seeing in the textbooks.
Congratulations once again. I asked you several questions during the surgical session, but now I will not gonna ask the same. But how would you think? What's the best method to identify aberrant hepatic arteries, and then to start the decision-making process regarding the extent of surgery?
So the best way in research to do it is, of course, by doing an anatomical dissection, because we are certain if there is one or there is not one. But
in surgery?
In surgery, yes. In surgery, I think it's computer tomography with the contrast.
I would disagree. It's the same as in research. So it's high quality surgery with very meticulous intraoperative dissection. And the second thing, how do you think why there is no single classification of aberrant hepatic arteries, and all these new authors propose new classifications?
Why there is no, or?
There is no widely accepted. There is one accepted, you've shown it, but no one uses that classification.
Yes, so I think that the reason for this is that the different authors aims for different clinical scenarios, and the classification that consists of 26 types, I'm sure that is of some use for the transplantologists and surgeons that are working with really close relation in the liver and biliary ducts. And the other classifications done by some other researchers maybe try to emphasize their truth and their way of thinking about those anomalies. In my classification, I try to aim at the general approach for general surgery, and maybe this is not the best classification for type of surgery involving the liver transplantation, but when there is a radiological preoperative assessment of the abnormalities of the arteries, the surgeon, general surgeon, can have a really simple and yet very important information that the variant artery is in the region that he is going to operate on or not.
I understand. So I wasn't supposed to ask it, but if you went to that point, so do you know what's the risk of clinical consequences when you accidentally close the aberrant artery during the surgery? You don't want to close it, but you close the artery. What is the clinical consequence of such?
So,
in majority of cases,
there are two scenarios. If the aberrant hepatic artery is an accessory hepatic artery, then there can be no consequences at all, because the arterial blood supply is remaining the same, and the liver is still nourished. However, if the accessory hepatic artery is providing majority of the blood to the region of the liver, or the replaced hepatic artery is seen, there can be several clinical consequences, such as the liver lobe ischemia or necrosis, or there can be a lot of complications which are connected to the biliary ducts and the
That's all true, but in 90% of cases there are absolutely no consequences of closing the aberrant hepatic artery, whether it is replacing or accessory. This is the case, but congratulations, this is a lot of work. Thank you.
Thank you.
Thank you, and thank you everyone for participating in this session. First and foremost, we would like to praise once again our jury for being here and assessing each of your presentation. We are honored and grateful for your presence.
A big thank you should be also given to our active participants. Your presentations were very compelling and insightful. Last but not least, thank you to everyone participating in this session. We hope you've had a good time and gained a lot of knowledge. It was an incredible honor to be your host today. The official results on this session will be announced at 5 p.m. at closing ceremony. Now we invite you to we start our keynote lecture.